Yep.
Awesome. I'm going to leave it at a presentation mode for fear of any more technical difficulties
Yeah,
this morning. So,
that's a good move. Good move.
all right. So, starting with this case presentation, I'll just go ahead and get underway. 37-year-old male who was transferred from an outside hospital for evaluation of headache, fever, right-sided weakness, and abnormal brain MRI findings. He was admitted to the outside hospital, the same one, about 1 month prior for similar symptoms. At that time, had an MRI that was concerning for abscess more than an infarct. A lumbar puncture showed that he had neutrophils. PCR and cultures were negative, though. He was treated empirically with antibiotics and steroids, had some improvement, and was discharged home. But regrettably, in the time frame of going home, he ended up worsening in the same flavor and came back. And so they called us and said, hey, his MRI is looking just a little bit worse. Is there any way you can help us out? So we transferred him, and on arrival, his significant exam findings, he was awake and fully oriented. A little bit of intermittent confusion with more complex questions, but not too bad. He did have some mild upper motor right facial weakness, otherwise no notable cranial features. And then on his motor examination for his extremities, he had some right-sided weakness to his arm and leg, about a 4 out of 5, but otherwise nothing else abnormal. And so we were able to pull over his MRI imaging from the outside hospital. Here's the axial flare, and you see this flare intensity kind of on the left side here. That's tracking from the pons up to the midbrain here, and then a little bit of like anterior thalamus, basal ganglia with a little bit of crossover to the other side. If you look at contrast enhancement for that, you see that it's a little bit kind of patchy through those areas where there was flare intensity. And if you look at diffusion restriction, he has kind of some scant diffusion restriction, but not as much as the contrast was. And this did have ADC correlate. And so that night, we ended up putting in for our own radiologist to interpret this image series. And interestingly enough, when we came back in the morning, they said, hey, this kind of looks like neuro-Behçet's syndrome, just based on the appearance, the presentation, and whatnot. And so, whenever I'm wondering why radiologists can look at something and go, that kind of looks like that, I like to reference my favorite website, Radiopedia, which is basically like a Wikipedia for radiologists. So typical features of neuro-Behçet's include lesions with a predilection for brainstem more than basal ganglia, more than thalamus, less commonly in the spinal cord, has some vasogenic edema, but little mass effect. There's patchy enhancement and plus or minus scant DWI. And so that kind of piqued our interest to look at him a little bit closer. So we went to go talk with him that morning and tried to ask him kind of those sequela questions of Behçet's, for which he said he didn't notice any. But as we were examining him, we look in the back of his mouth and he has these two giant aphthous ulcers. I'll note that this one is actually post biopsy on this side, but he had one here and one here. And so we said, interesting. So we ended up repeating a lot of workup for our own regard. Repeat lumbar puncture showed that he still had a neutrophilic predominant CSF. He had an elevated CRP and an ESR. His biopsy of that site was kind of more non-specific, unable to differentiate between Behçet's versus just the regular aphthous ulcers. However, in my reading on Behçet's, it seems that for oral mucocutaneous lesions, it's kind of hard to find those frank features of vessel inflammation that would be indicative of vasculitis. But to save the rest of the story, the remainder of his workup ended up being pretty unremarkable. And so his hospital course ended up kind of being a discussion between consultation groups with infectious disease and rheumatology. And we felt that his presentation would be consistent with neuro-Behçet's. So we started him on high dose steroids for 5 days, followed by oral prednisone. And during that window of time, he actually noted some improvement. And so we started him on Cytoxan prior to discharge. And thankfully, he was actually able to discharge to acute rehab despite his initial presentation. And so that's kind of his story in a nutshell, but just to kind of give like a brief disease summary, Behçet's is systemic vasculitis, involves blood vessels of all sizes, both arterial and venous, classically characterized with the oral aphtha along with other systemic features. It's endemic to populations along the old historic silk trading road, kind of Mediterranean to Eastern Asia, but the highest prevalence is interestingly in Turkey. Neurologic complications occur less frequently in cases. It's about 10%. Most common manifestations are parenchymal lesions like the one we saw, or vascular thrombosis. And I thought this one was interesting. Unlike other vasculitic disorders, peripheral neuropathy tends not to be a common feature. Parenchymal lesions, like we talked about, tend to have a predilection for brainstem more than basal ganglia, more than thalamus. On CSF studies, interestingly, neutrophils tend to be the more predominant feature of cell type. Biopsies tend to not show frank vasculitis, so that makes histopathologic confirmation a little bit of a pain. And for neurologic involvement, treatment tends to be more aggressive on the scale with glucocorticoids and disease-modifying agent of choice, whether azathioprine, mycophenolate, or cyclophosphamide. And overall, with neurologic complications, course tends to wax and wane, and exacerbations or remissions can happen. And that's the case.
Thank you, Ben.
Any questions?
No questions. We'll, but thank you for that wonderful presentation.
Aye.
And there's our CME code again. All right, today's grand round speaker is our own Katy Peters. Katy is an associate professor of neurology and neurosurgery and a member of the Duke Cancer Institute. She got her MD and PhD at Stanford. I first met Katy when she was a neurology resident at Johns Hopkins. And then she came to Duke to do a fellowship in neuro-oncology and has been here ever since to our delight. Katy is a prolific author dealing with therapies for brain tumors and for side effects and quality of life in patients with brain tumors. She has over 80 publications. But as we all know, Katy is more than just the sum of her parts. She's perennially ranked as one of Duke's best doctors and best teachers, and one of Duke's most outstanding personalities. I've known Katy a long time, and she has not changed a bit and has always been someone who's incredibly warm, approachable, and an incredible doctor. Katy's going to talk to us today about an evolution in the treating of low-grade gliomas. So, Katy, thanks for agreeing to talk, and I will throw it to you.
Thank you so much for that warm introduction. I really appreciate it. Wow, I am going to attempt. Thank you so much, Rich. Thank you, Will. Thank you for inviting me. Thank you to everyone for being here this morning. I hope you can see the slides okay. I am going to attempt to use slideshow, so just let me know if it technically gets to be challenging. Does it all look good?
Yep, got it.
Good. Yeah, got it. Great, perfect. So we'll get started. I'm going to talk today about low-grade gliomas and how treatment has changed. I really appreciate Rich's introduction. I do want to give a few things, about 5 things about me, just to give you updates about what's going on. First is I'm from Tennessee. I just got back last night. I drove from a really small town around Tullahoma and drove across. And the reason why I was there is I got to see my family for the first time since 2019. The whole pod's been vaccinated. Next is I was trained by Rich O'Brien at Johns Hopkins. One of my favorite quotes of his is, if you can't hop backwards on 1 foot out of the ER, you probably should be admitted. So I remember, I remember that quite well. I think it holds true today. Next is I have a Southern accent, so please don't adjust your Zoom volume. That is how I sound. And I have over 500 Swatch watches. I'm wearing one today. So I always know what time it is. And I have 2 perfect cats. That's my little Ember on her harness, and of course, Daisy Duke. So let's get talking about low-grade gliomas. So I see primary brain tumors in our clinic, and it's great when the neurology residents come to work in our clinic and come to learn. They do see a fair number of low-grade gliomas because even though they're uncommon, they make up a large part of my clinical practice. But in general, they only make up about 5 to 10% of all primary brain tumors. And what low-grade means is essentially how aggressive the tumor looks underneath the microscope, where high-grade are really glioblastoma, which are more common. You'll see lots of mitoses, lots of pleomorphic cells. The low-grade gliomas just show an abundance of cells, but not many mitoses. The median age of onset is around the 3rd to 4th decade of life. And so this can happen when people are planning to have transitions from schooling, maybe they're starting jobs, maybe they're starting a family, maybe they're getting married. So this diagnosis is at a very challenging, this cancer diagnosis is at a challenging time of their life. And the common imaging, and we saw some interesting imaging from that great Bichette's case presentation, but what we see here is really T2 flare abnormalities. And I've just sort of given an example across the board with the different names of these tumors, astrocytoma, oligoastrocytoma, and oligodendroglioma. And you can see sort of these patchy areas of T2 flare abnormality. They usually like to occur at the insula or temporal lobe, or some tumors have a predilection towards the frontal lobes. The clinical presentation is truly a neurologic presentation. Seizures are very common for this class of tumors, but a lot of times this can be included in a workup for headaches. Again, I just described the imaging before. Some pearls that I like to tell the residents in particular is that oligodendrogliomas can have some patchy enhancement, and additionally like to sit in the frontal lobe. Now, despite the term low grade, these patients can experience very significant impairments to their quality of life. And this is a lot of my research is looking at the quality of life impairments in our primary brain tumor patients. And these can include seizures, fatigue, cognitive disorders, and I've listed all of them here. And it can be caused by the tumor, and sometimes it can be just caused by the treatments that our patients have to undergo to treat their brain tumors. And we're going to go over those treatments in depth. But first, I want to highlight some research from our supportive care research group and my colleague, Dr. Mary Lou Affronte. And what she wanted to look at is, since our patients have those neurologic and cognitive problems, along with having seizures and headaches, we wanted to see what type of adaptive strategies our low-grade glioma patients have. So what she did is she had a descriptive study where we looked at the trajectory of symptoms in low-grade glioma patients and those adult patients, and then looked to see what type of adaptive strategies they had to overcome those challenges. And this was supported by a grant from the School of Nursing. And in this pilot study, we showed in 15 low-grade glioma patients that went under these qualitative interviews that the most common symptoms they had were, again, seizures followed by fatigue and memory problems. And emotional problems seemed to peak around 4 months after diagnosis. But what was greater about our patients is they actually did start to adapt some strategies to help overcome those challenges. And one was obtaining community support and managing expectations and developing support symptoms. Those were really the most common ones seen. And at the end of my slides today, I'm going to show you some examples about obtaining that community support for our patients, which is extremely important. So let's go back to the histology and the pathology and what does it mean. So I already told you what a low-grade glioma means, but what helps us guide in our diagnosis is the World Health Organization, which we've heard a lot about during COVID, but is also involved with defining and understanding cancers. And in 2016, or before 2016, really all we had was how do we describe these tumors histologically? And in this first panel, this is a classic astrocytoma, where you see abundant cells here throughout the brain that are infiltrative, not many mitoses. Over here on this panel, you see, again, abundant cells, but there's a halo around these. This is a fixation artifact, and this is classic for an oligodendroglioma. And then a mixed subtype, which shows astrocytic cells and oligodendroglial cells and mixed together. But in 2016, there was really a nosological shift where we didn't just use the histology anymore. We used the molecular determinants, sort of the genetic determinants of those tumors, and those were integrated in how do we make a diagnosis. And this is probably the most, really the most, and the discovery of isocitrate dehydrogenase 1 and 2 mutations in gliomas was actually done here at Duke by Dr. Hai Yan. So this is really a Duke discovery and really changed how we diagnose tumors. So in this algorithm, you could have all these histological diagnoses, but depending on the status of that mutation, you can further subdivide these tumors into different categories. And you can, so essentially you can have IDH mutant versus IDH wild type, and then further subdivided whether they had a 1p19q chromosome deletion or p53 mutations would define whether you have an astrocytoma or an oligodendroglioma. So it's no longer just looking underneath the microscope, it's actually pushing to the next step that you can actually do molecular analysis of these tumors. I'm not going to mention glioblastoma today, even though it's the most common. Now, what's interesting is this subtype, the oligoastrocytoma, really fell out that it doesn't really have a place anymore. If you know the IDH status and you know also these p53 and 1p19q co-deletion status, you can really put them in the bins of astrocytoma or oligodendroglioma. So this is very important to know that really you really can't have an oligoastrocytoma unless you don't know the IDH status. So this is just what I described, that prior to the WHO guidelines, it used to be we would lump all these tumors together, but now we're able to separate these out, and the genotype and phenotype are now driving how we group these tumors. And these are the key mutations, and I'm going to discuss these. So the first is isocitrate dehydrogenase 1 and 2 genes, and we define it as either mutant or wild type, 1p19q chromosome co-deletions, or telomerase reverse transcriptase promoter genes. And if there's any medical students in the audience, or perhaps our residents, you'll recall that isocitrate dehydrogenase is a key component of the Krebs cycle, and it converts isocitrate into alpha-ketoglutarate. But when you have this mutant enzyme around, it takes the alpha-ketoglutarate and in turn converts it to 2-hydroxyglutarate, which is termed an oncometabolite. This oncometabolite turns on a series of genes downstream, which actually leads to cancer formation and tumor genesis, particularly gliomagenesis. And we're not the only cancer that has this gene mutation. It's been well characterized, particularly in AML, chondrosarcoma, and cholangiocarcinoma. And this is Hayan's work published in the New England Journal of Medicine, showing that these IDH mutations were occurring in these low-grade gliomas, but were quite rare in glioblastoma. So again, these are very common mutations in this type of tumor. And he was able to show that patients that had these mutated tumors had a better prognosis than ones that had wild-type tumors. So this is an example of a Kaplan-Meier curve. And I want you to focus in more on the anaplastic astrocytoma, because these are where the really meaningful results are, is that if you had a wild type tumor, you had a poor survival compared to patients that had an IDH mutated tumor. So recently, I was able to present some of our research at the Society of Neuro-Oncology, and we looked at how this gene could be mutated. The traditional or classic mutation is at the 132 codon, which leads to a mutation from arginine to histidine. And that's approximately 90% of the mutations. But there are other mutations in these genes, the IDH1 and IDH2 genes, that are considered non-canonical. And so we sought to compare the clinical characteristics of low-grade glioma patients that had sort of that classic mutation versus ones that had the non-canonical or the IDH2 mutation. And so in an IRB-approved registry, we actually just queried those patients who had low-grade glioma, and then we looked at only the patients that had standard PCR data for DNA sequencing for the point mutations at the IDH1 and IDH2 genes. We further then looked at time to event endpoints to see if those, if there were differences between the classic or the non-canonical mutations. And this is our breakdown. We actually found, in addition to seeing that most of our patients had this classical mutation, which was really 84% of our patients, we did find different mutations across the gene. So you can see here, some are at the R119 codon, some at the R72, and then the R132 could be mutated, but maybe it's to a different type of moiety for those patients. And when we did a statistical analysis for those groups, we found that the median age was slightly lower for the IDH2 mutated groups. And there was a striking difference in the diagnosis for the non-canonical group that had a higher proportion of astrocytomas and a lower proportion of oligodendrogliomas, either the classic IDH1 or IDH2 mutations. And this is typified here that, again, our IDH2 patients were actually quite younger and it was statistically significant. And then our patients that had the non-canonical mutations tended to be more enriched with the astrocytoma subtype. We next did analysis of time to event endpoint. I wanted to focus in on progression-free survival because this is a key endpoint for low-grade gliomas because it often drives when we start interventions for our patients based on the time that they progress. So this is an example of progression-free survival rate. And what we see here is that PFS actually differed significantly between the groups, such that our IDH2 mutated patients did much better, okay, and had a better progression-free survival than our patients with, usually the IDH2 mutations is the black line, compared to our non-canonical mutations, and even the traditional classic IDH1 mutation. Now, this didn't really have a difference between time to progression or overall survival, but again, progression-free survival is a key determinant in when we start to treat our patients with low-grade gliomas. So now I'm going to switch to a little of the neurology side of neuro-oncology, because again, the most common presentation for our brain tumor patients with low-grade gliomas is to have some type of neurologic phenomenon early on. And the most common one seen is seizures. And so in a nice analysis that was published in the Green Journal by my colleague Craig Horbinski out of Northwestern, they did a retrospective analysis of a large cohort of glioma patients, about 700 glioma patients, and found that perioperative seizures were much more common in those patients that had IDH1 mutations. They then further did a series of experiments that showed that that oncometabolite that I described before, the 2-hydroxyglutarate, well, it doesn't just cause tumorigenesis, but it seems to increase the firing of cultured neurons. Moreover, they were able to find that these IDH1 mutant cells would track along gray matter and track along neurons, and that 2-hydroxyglutarate can actually lead to postsynaptic potentials and activate action potentials. So a really nice paper, but really describes why our patients in this group could be having more seizures. And it also gives us an opportunity that we could target this to potentially treat seizures in our brain tumor patients. And I'm going to talk about how we can even target this, these mutations to treat the tumors themselves. So in just knowing about brain tumors, particularly low-grade gliomas, I've talked a lot about IDH status, but I also want to talk about the company that they keep, the other genetic alterations, because it seems that it's not just the IDH status that's important, it's also the other genes that are mutated. So 1p19q co-deletion actually was discovered before IDH mutations, and they've known for a long time that 1p19q co-deletion does predict increased chemosensitivity and a better prognosis. So usually what we find is that if you have an IDH1 mutation, you also have a 1p19q co-deletion. So that is associated with a very good prognosis. Now, TERT is a mutation in the promoter of telomerase reverse transcriptase, and it increases the production and the maintenance of telomeres. And it is commonly found in glial tumors. It's actually one of the more common mutations, primary glioblastoma. It's also found in other cancers. And what's interesting here is it's really important to know the IDH status before you know the TERT status, because it's really about the company you keep. What is the IDH status of those tumors? Because if you have mutant tumors and you have a mutation, it has a much improved prognosis over just being IDH mutant alone. But if you have IDH wild type tumors and the patient's tumor has a TERT mutation, it's a very poor prognosis. And we actually call that a molecular GBM. And what that means is even if it doesn't look like a GBM underneath the microscope, if it has the molecular characteristics of a GBM, it's going to behave like a glioblastoma. And this was really well described by Passau and colleagues. And I would say that I use this paper routinely in our clinic, and I really want you to focus on the top pane. And what they did was they looked at a large number, around over 600 patients with both grade 2 and grade 3 gliomas, so low-grade gliomas and those anaplastic cohorts, which are grade 3. And they looked at survival using Kaplan-Meier analysis and based it on whether the mutations of those tumors, whether they had TERT mutations and IDH mutations, whether they were triple positive, that means adding in the 1p19q co-deletion status, IDH alone, whether they were triple negative or had that TERT mutation alone. And what they found is if you had an IDH1 mutation, you have a much, much better prognosis than if you don't. And if they did have a TERT mutation alone, that this curve almost looks very similar to a glioblastoma. So this finding in 2015 really prompted those changes for the World Health Organization in 2016. And now with updates for our pathology and the C-impact guidelines, it really is pushed molecular analysis to be, is the gold standard to understand the prognosis for our patients. So next I'm going to talk about is the steps of how we treat our patients, our low-grade gliomas, and I'm going to talk about sort of where we're moving towards. And it's really a multimodal approach to treat low-grade gliomas. And the first step is to get a proper diagnosis. And this is key, and maybe it's not as key as it used to be because we are focusing so much on the molecular analysis, but it's important to note that roughly about 40% of what you think looks like a low-grade glioma, because it's non-enhancing, will end up being a high-grade glioma. So getting enough tissue out and getting it out safely is really important for grading. But now that we have the molecular analysis, and maybe a little less so. We also know that if we want to watch our patients, if surgery does become delayed. Now the surgery, I would say at Duke, is very rarely delayed because we have a very large amount of neurosurgeons that are highly competent using great tools. But again, if you are just watching a patient and you're watching, unfortunately, something grow on their MRI, something that grows much more quickly with a larger growth curve is going to have a poor prognosis versus something that is growing more slowly. And that just seems to make sense, but that's the classic rubric. So how do we treat our patients? It takes a team of providers to treat our brain tumor patients, particularly low-grade gliomas. We have our neurosurgeons, our radiotherapy team. I like to say this is our neuro-oncologist giving chemotherapy. I like to say I'm a little samurai. And then of course, all the neurologic here. I love this picture. I don't know what they're injecting the brain with, but I think that's an EEG. I may not be sure, but it could be. That's the neurologic care. So what is the rationale for treatment? So for surgery, there's never been a randomized controlled trial, and I don't think there ever really will be, but probably the best study is by a group in Norway, which showed if you had an early resection, you tended to do better than if you just had an initial biopsy. And we do know that in myriads of studies that the size and extent of the tumor are independent prognostic factors for low-grade gliomas. And now that we have great techniques like functional mapping and awake craniotomy, we can really refine how we do those surgeries for low-grade glioma patients. And there's even some surgeons that will do multiple resections to try to get out as much tumor as possible for those patients, but do it in a safe manner. Next is our radiotherapy, and this has been probably the most studied in this population because radiotherapy has long been a tool in the brain tumor community. The most important trial is the EORTC 22845 trial, which compared early versus delayed radiotherapy for high-risk, newly diagnosed low-grade glioma. And in this, they found that progression-free survival can be improved with radiotherapy, but overall survival didn't seem to be changed. So this sort of brings up the question of when do we give radiotherapy to our patients? Because the other observation, and this is again a little bit more of the neurology side of neuro-oncology, is that radiotherapy invariably will cause cognitive dysfunction. And this is a series of graphs from a study by Dow and colleagues, where they looked at patients with low-grade glioma that were long-term survivors, and they looked for ones that had no radiation therapy, which is the red line, versus the green line, which did have radiation therapy prior. And you can see that their mean scores on cognitive tests were poor. And these can be best seen in tests of attention. We can also see it with executive functioning. And I've done some similar work in survivors of high-grade glioma, which shows very similar results. So we know that even though radiation could be a very useful tool to our patients, we also know that it can cause cognitive dysfunction. So one of the big questions in the radiation oncology community, in the neuro-oncology community, is that radiation is a good tool, but when should we use it? And this is why the progression-free survival point is so important, because should we wait till it's progress to treat them with radiation therapy? So it's still a big debate. And probably the most controversial part is really chemotherapy. And this is where most of the data, and this is one of the challenges with low-grade gliomas compared to doing studies with other cancers in the brain tumor space, is that these patients live a very long time. So endpoints are very long, but which is a good and positive thing, but what can happen is science can move along while we're sort of waiting for studies to get an endpoint. So in a classic study called RTOG 9802, it was a randomized phase 3 study where they looked at radiation therapy with a combination of chemotherapy called PCV after radiotherapy. And it did show that there was overall improvement of survival with the combination group. But do we still use this combination chemotherapy? And I will tell you, these are the two graphs. So it did improve progression-free survival, the combination. It also improved overall survival. You can see how many years after randomization that this happened. And this is published in 2016. But what happened between 2005 and between the start of the study and to when it was published is that the tools that we used in the neuro-oncology community were changing. And one was an introduction of a drug called temozolomide, which was similar in action to some of the components of PCV, but also just a much more tolerable. So one would predict that based on this, I would be giving all my patients with low-grade glioma PCV, and they'd all be getting radiation that had low-grade glioma. But I would say this is not the case. And the reason why is so much happened in the development. We started to learn about those IDH mutations, that patients may not have a poor prognosis. Some may have a very good prognosis. Next is, could you choose a less toxic chemotherapy? We were now giving temozolomide, which is the standard of care for brain tumor patients with glioblastoma, and it's extremely well if you had to list all the chemotherapies in a space. So clearly there's a lot of debate on like, what should we do for these patients? Because we don't want to give these young patients a chemotherapy, and maybe we don't want to give toxic radiation early on. So it's almost as if those studies, sort of the evolution of treatment started to happen before we really got the results of the final studies. And this is just my primer on chemotherapy for neurologists. What is PCV versus temozolomide? So PCV is 30 chemos, procarbazine, lomustine, and vincristine. And many of you probably know vincristine just because of it can also cause neuropathy. So it can be a serious complication for our patients. It has to be given IV for some of the agents, and it can cause a lot of side effects. So it's IV administration. It's harder to tolerate. There are drug-drug interactions. and procarbazine causes a tyramine reaction. But temozolomide, which is the standard of care for GBM, it's oral medication. The schedule is much easier, and it's easier tolerated, easier to deliver, and it's the standard of care for high-grade glioma. So it can be translated as such. So there's no prospective trials comparing TMZ to PCV in low-grade gliomas, but there was one in high-grade gliomas. This was really grade 3 tumors. And what they found was there was really no difference between overall survival and progression-free survival. So how do we use all these little pieces of evidence to say what is the standard of care for low-grade gliomas? And I'm actually on a panel for the American Society of Radiation Oncology right now, where we're trying to answer these questions just about what is the appropriate treatment for our patients. The next is can we also give temozolomide instead of even giving radiation? And so this is an early study. This is the EORTC 22033 study, where they looked at high-risk low-grade glioma patients, and they list the risk categories here. And radiotherapy and temozolomide seem to have the same progression-free survival. There was no significant difference. There may be something happening later on that's splitting here and changing, but only time will tell what these results will be. So in a subset of those patients, and I think this is an interesting study, they actually looked at just the IDH mutant patients. And what's important about this past slide is I listed all these high-risk factors, but this study really started before we really were using IDH status as a predictor of survival for our patients. So it wasn't included in the high-risk, low-risk stratification initially on, but there was a subset of patients, for about 120 patients in that trial, that did have IDH status, and there were in fact IDH mutants. So you could argue that they're no longer high risk because they have that mutation. And they looked at patients that both received, one that received radiation and some that received temozolomide, and they gave them a score on a sensitivity marker called methylguanine methyltransferase, which is an enzyme that repairs temozolomide damage. But we also know that patients that have a methylated MGMT, so essentially a turned off promoter of this MGMT, will have a better prognosis overall and sensitivity to temozolomide. So they used the same scale in these patients, and what they found was that for the temozolomide group, this scale could be predictive of how they respond to temozolomide therapy. So they were essentially pointing at, and I think this is the first time that they really pointed to this, is there other markers that we can use that could predict potentially how patients with low-grade glioma respond to chemotherapy? So really nicely done paper. So sort of what we've sort of come to now is like, how do I treat, or what do we do with these patients? So I consider IDH status, I consider TMZ instead of PCV because of toxicity. The timing of the radiation, I always go for a quote from John Kirkpatrick, who's our radiation oncologist, who says, it's likely not going to be avoided. The question is, when are you going to start to treat? And you want to consider clinical trials for low-grade gliomas. And maybe the clinical trials of the past, they're really focused on long-term outcomes with survival, but we need to think about how we can do something maybe a little bit more novel for our patients. So for the following patients, for an oligodendroglioma who has a grade 2 IDH mutant 1p19 code deletion with a good surgery, I'll just watch them usually and watch to progression, till progression, and then do other treatments. But if they're an astrocytoma that has maybe a TERT mutation and is IDH wild type, which may be a molecular GBM, I would treat them like a glioblastoma. So I want to now switch gears and really talk about how we're changing. I needed to give sort of the historical perspective to sort of show you how are we moving forward with new avenues to treat these tumors. And this is just a tumor specimen staining with that IDH1 mutant protein. And I want to talk about two studies. One is a study using a compound called Boracetinib, which is an oral agent that inhibits these mutant enzymes. And we've done a phase 1 study with a dose expansion, And now we're in a phase 3 study looking at this. And then resist, which is a peptide vaccine to the IDH1 mutant protein, which is a phase 1 study. So a company called Agios is now called Servier, started development of looking at small molecule inhibitors for IDH1 and IDH2. The first in class compound is called Tibsovo. It only inhibits the IDH1 mutant enzyme. It has been shown to be, it was shown to be effective in AML, and recently had a very positive study for cholangiocarcinoma in the phase 3 space. We have studied it in recurrent non-enhancing gliomas, and it did improve progression-free survival, but it's very hard to get across the blood-brain barrier. And you have to give very high doses of the agent to achieve any kind of response. So a second generation compound is called Boracetinib, and it's an oral potent reversible brain penetrant inhibitor. And it inhibits both the IDH1 and IDH2 enzymes. And it very easily crosses over the blood-brain barrier. I'm going to show you some data in regards to that agent. So this is a phase 1 study. It was multi-site. I, along with my colleague, Dr. Mellinghoff, were involved with this study. He was the lead PI on this. And we looked at and had both gliomas and non-glial tumors. We looked at a small cohort of non-enhancing gliomas, which tended to those low-grade gliomas, and these were sort of the outcomes that we were looking at, and we're really just looking at safety for the first round. We started in a classic dose escalation model where we increased from 10 milligrams up to 300 milligrams, never made it up to the 300 milligrams, but again, treated it, I'm going to just focus really on those non-enhancing recurrent patients. And these were patients that could have had prior therapy. So these are not newly diagnosed. These are low-grade gliomas with non-enhancing that had recurrent disease. In showing this waterfall plot, we can see that patients that received Boracetinib, most of them did quite well. Their disease either was stable or they had a minor response, 3 patients did, and 1 patient had a very nice partial response. But again, this is a very good response rate. Above 72% of those patients are actually had some stability of their disease. So pretty exciting results for this. And again, the progression-free survival was improved primarily for those non-enhancing glioma groups, which I show here in this Kaplan-Meier curve. And one of the safety concerns of the drug was that it did have a little bump of the liver enzymes for patients that received the agent at higher doses. So we decided on a dose of 50 milligrams for the Boracetinib. And the second study that we also enrolled in here at Duke was a very interesting study where we looked at patients that had recurrent mutant IDH1 tumors that were non-enhancing. They could be grade 2 or grade 3 patients. They were randomized to receive either Tibsovo, which is the IVO, or Boracetinib, along with some patients that were enrolled were just controls. We then treated them with the drug and then did surgery, and we're just asking the question of, can we suppress the 2-hydroxyglutarate, that 2-HG, that we believe is causing the tumor? And then we further allowed the patient to remain on drug afterwards. And so this is just an example of our patients. We had 49 patients that were randomized along with those control patients that were evaluated in the study. And this is just the breakdown of how they were treated. And this is probably the most important part of the study, was what happened to that 2-hydroxyglutarate level. So in this graph, this is the groups, okay? And this is one that's corrected, and this is just the raw concentrations. I'm going to focus in on just the raw right now. So this is the IDH wild type reference, which you would not expect any 2-HG. But in patients that had the reference IDH1, you'd see a high amount of 2-hydroxyglutarate. Also the same for the untreated controls. But when we treated with Boracetinib, for those IDH mutant patients, you can see there was suppression of the 2-hydroxyglutarate. So we were pretty excited that we actually could see that the drug was doing what it was supposed to be doing. And we had a nice objective overall response rate, very similar to those previous studies that I mentioned before, with a lot of stable disease. Both drugs were able to have some minor and partial responses, but very few progressive disease. So a very good candidate. I just want to show you what this looks like. This is just an example of one of these patients. This is a 31-year-old male. He had a left parietal oligodendroglioma that was IDH mutated. He had been on a study with Everlimus, which is an mTOR inhibitor, and he was enrolled for progressive disease. And so you can see this abnormality on FLAIR imaging crossing over the corpus callosum. You can see that this is cycle 1, day 1 post-operatively. And then as they were continued on the drug, you can see the reduction of this FLAIR abnormality at the corpus callosum and around the resection cavity. Moreover, they looked at how this compared to the 2-hydroxyglutarate reductions. And this was an example of one of the patients that had a very robust reduction in 2-hydroxyglutarate. And this patient remains on therapy. And I will tell you that the patients that we treated on the study, which was earlier in 2018, they're still on study drug for all the patients that were enrolled here at Duke. So doing quite well and not progressed. So this has led to a global initiative, a phase 3 study to look at patients. And what's different here is we're not looking at patients that have disease anymore. We're looking at patients that could have only had surgery, but they could be stable or they could have just measurable residual or recurrent disease. So they don't have to, it doesn't have to necessarily be recurrent, it just has to be measurable. And they're randomized to receive either Boracetinib or a placebo, and the primary outcome is going to be progression-free survival. And this is now open internationally, and I'm happy to say that we're the number 2 enrolling site on this. We're trying to go for number 1 for this protocol, but we're pretty excited to be involved with it. Additionally, in this study, we wanted to understand what's happening, what else is 2-hydroxyglutarate doing? And there was some interesting suggestion that 2-hydroxyglutarate is very permeable, and it may in fact suppress pro-inflammatory gene in macrophages, but also T-cell infiltration. So in that same group of patients where we removed the tumors in the perioperative study, we looked at T-cell infiltration, and what we found is in the untreated group, you can see a very low level of T-cell infiltration. In patients that were treated and had a reduction in 2-hydroxyglutarate, the T-cell infiltration was much improved. But if you had treated patients and the 2-hydroxyglutarate was not suppressed like it should be, those T-cells did not infiltrate as well. So what this is suggesting, and it's also been suggested from other experiments, is that 2-HG may suppress T-cell activation. So could you have an opportunity, particularly with immunotherapy, to target IDH1 mutant tumors via the IDH1 mutation, and maybe even suppress 2-hydroxyglutarate and improve immunologic reaction for those patients? And so here at Duke with John Sepson and Dr. Hai-Yan, and this is a presentation I presented at in 2019 at the Society of Neuro-Oncology meeting, we developed a tumor-specific peptide vaccine that targeted the IDH1 mutant protein. And this is just an example of how that was developed. And this was a first-in-human safety study of the peptide vaccine in recurrent IDH1 mutant low-grade gliomas. And in this design, we enrolled recurrent resectable patients. They received the peptide vaccine along with a peptide with a tetanus booster. They then had resection. If they transformed, they went to radiation and temozolomide. But if they were just remained a grade 2, they received temozolomide with the peptide vaccine. We enrolled 24 subjects. This was 2015 to 2018. At least 20 subjects got the 6 peptide vaccines. and 16 subjects received all 15 vaccines and completed the study. And this is just our breakdown of our patients, just to show you what they looked like. And for courtesy of time, I'm just going to quickly show the rest of these slides. The most common side effect was injection site reaction. This was very well tolerated. These vaccines, peptide vaccines, are very well tolerated, do not cause any other myelosuppression associated with them. We did have some myelosuppression from the temozolomide, which did require some patients to be discontinued from study, but the vaccine itself was extremely well tolerated. And this is our swimmer plot that just shows that our patients have done quite well with this. We continue to follow for survival, and we're looking forward to publishing not just this, but also the immunologic results. There was a recent publication that came out from Dr. Michael Platten that showed you can have, they've also done a similar vaccine for high-grade glioma patients with the IDH mutation, and then it's also can be immunogenic. And the initial results of ours is that it's immunogenic also. And so we're really excited about this technology. We're looking forward to continuing to follow these patients. We integrate a biomarker using neuroimaging with MRS, which is spectroscopy for 2-hydroxyglutarate. It actually can be found in a little itty bitty tiny peak. I'd love to come back and share this with you. This is in collaboration with Dr. Brian Sohar in the neuroradiology department. But again, we're very excited about this technology, and we're looking forward to utilizing this vaccine in other trials with our patients. And just for a teaser, we have designed the next study. We call it Victory. And this is, we want to use the Boracetinib in combination with a tumor-specific peptide vaccine for recurrent IDH1 mutant lower grade gliomas. So in this study, we would enroll those grade 2 and grade 3 patients, give Boracetinib to suppress the 2-hydroxyglutarate theoretically, thus sort of releasing those T cells to hopefully be activated by that peptide vaccine, and then further continue the vaccine along with the Boracetinib. So we're hoping that this study will be funded and we can move forward with it. So in summary, 5 things you sort of need to know about this talk, and I hope that you learned, is that the prognostication for patients with low-grade glioma is really important in understanding their genetic makeup. I hope that we covered that, and that surgery is the first step in making the treatment diagnosis. And other therapeutics in radiotherapy and chemotherapy are important, but timing is still being debated, and even sort of how we're supposed to give it. And then targeted IDH1 therapeutics are a promising new approach in how we can treat those low-grade glioma patients. And I will tell you, in one of the other endpoints in the Indigo study is actually seizure control. So we're pretty excited because that 2-hydroxyglutarate may not just also treat tumors, but also seizures. And then I just appreciate the time and opportunity to give this presentation. Last slide, just want to thank everyone at the Brain Tumor Center, all the research colleagues, particularly John and John Sampson, and the group at Agios. I told you I would talk about the adaptive strategies of patients. You will now see my cat too, sorry, she had to make an appearance. The adaptive strategies for these patients is also forming groups. This is a group of low-grade glioma patients on a run. They were featured in Brain and Life magazine. So it's really important to have those strategies. So they call themselves the Brain Brothers. So thank you very much. And that's the end of the show.
Thank you, Katie. If anyone has a question, just either put your name in the chat or put the question in the chat, and we'll call on you. So Katie, I have a question. Do these rules apply to gliomatosis? We had a case of that recently. Where does gliomatosis cerebri fall into this?
So gliomatosis cerebri is now no longer it's not considered a pathological diagnosis. It's just considered a pattern or an entity because it's really radiographic. You'd still be graded on your IDH status, whether it's low or high grade. And that's a good question, because it could be that, you know, if you had an IDH1 mutant tumor and you had a gliomatosis cerebri pattern, that you have a potential to do better and actually respond to one of these agents. So yeah, it's more of a pattern than an actual diagnosis.
You had a compliment from a fellow Tennessean, Janice Massey, who said, great talk. All right, I see it's 9:02. Katy, thank you so much, and thank you for the long ride to make this presentation.
Yeah.
How many miles is it?
It was around 500 miles.
Whoa. Whoa. Well, we're glad you're safe.
Yeah, it was. The storms were pretty tough going there, but we had beautiful weather on the ride back. So.
All right, everyone, have a safe day.
Thank you for inviting me. Bye-bye. Have a great day, everyone.
Bye-bye.